Can't kill a cockroach.
Hello. They're gonna have to hear more from me, I suppose.
Sorry.
They're gonna have to hear more from me, I
Hey.
suppose.
Nothing wrong with that.
Go ahead.
We get the point. Professor? Everyone, we're going to move to our next session. Guess our closing program session for today on wellness and ergonomics. So I'll ask everyone to take your seats or exit the room. So data suggests that between 40 and 80% of all practicing surgeons have experienced physical injury or lack of wellness during their careers. And in fact, approximately a fifth of surgeons admitted that they missed work or slowed their operative schedules related to these issues. So as an important part of the Southeastern Surgical, we must understand wellness and ergonomics and how we can continue to improve our careers. This afternoon, we have a distinguished panel who will discuss wellness and ergonomics. We have Dr. Amy Hildreth, who is currently the program director at Wake Forest or Atrium Health Wake Forest, soon to be the chair of surgery at the University of South Carolina in Columbia. Dr. Hildreth is currently, she received her MD from the University of South Carolina, and she has completed a residency in general surgery and a fellowship in surgical critical care at the University of Tennessee College of Medicine. In 2008, upon completing her training, she joined Wake Forest School of Medicine. Her clinical practice is in acute care surgery, encompassing trauma surgery, emergency general surgery, and surgical critical care. Amy is passionate about improving the care of surgical patients through quality improvement, research, and training the next generation of surgeons. She has been active in the Southeastern Surgical Congress since 2003 and serves on the Council of the American Board of Surgery. Our next panelist is Dr. Shanita M. Johnson. She's a professor of surgery and director of the Minimally Invasive and Bariatric Surgery Program and Residency Associate Program Director at Morehouse School of Medicine, where she's also serving as the interim chair of surgery. She's a native of Nassau, Bahamas, and she's a graduate of St. Andrews High School as the Alpha Kappa Alpha female valedictorian of the Bahamas. She attended the Johns Hopkins University in Baltimore, Maryland, graduated with a bachelor's degree in neuroscience. While matriculated there, she was awarded the Johns Hopkins University Multicultural Award for personal and academic excellence in addition to other honors. She received her medical degree from Loma Linda University in Loma Linda, California, and then completed a residency in general surgery at Howard University. While at Howard, she was awarded the American College of Surgeons Committee on Trauma DC chapter for research and also received the Chairman's Surgical Award. She has an interest in minimally invasive and bariatric surgery and completed her fellowship at the Cleveland Clinic. She's board certified in both general surgery and obesity medicine. Dr. Valentine Nefonsom is our third panelist, and he is a graduate at the University of Illinois in Chicago School of Medicine and completed his training at UT Southwestern in Dallas and North Shore LIJ in New York. He did a research fellowship at the Cleveland Clinic and completed a 2-year fellowship in colon and rectal surgery at the University of South Florida. He served as the program director of the general surgery program at the University of Arizona for 9 years, and we were fortunate to recruit him to LSU as our chair of surgery. He is a member of a number of important organizations, and Dr. Nefonsom also serves as a counselor for the American Board of Surgery. Dr. Brian Richmond is a native of Beckley, West Virginia. He went to Marshall as a part of the Thundering Herd and then matriculated into West Virginia University for medical school. He completed his residency there as well as achieved his MBA during that time. In 2017, he was awarded the title of the John J. Mayer Endowed Professor of Research, or Chair of Research, and in February of 2020, he became the Burt Bradford Professor and Chair of the WVU Department of Surgery, in a position that he holds today. He is currently serving as our president of the Southeastern Surgical Congress, and he is a counselor of the American Board of Surgery. And finally, we have Dr. Allison Smith. She's a native of Pittsburgh, Pennsylvania. She's a graduate of Virginia Tech and completed her medical school training and general surgery residency at Tulane University. In 2014, Dr. Smith completed the physician scientist training program at Tulane University, and her thesis was on the use of stem cells to treat chronic wounds. In 2019, she received recognition as Resident of the Year from University Medical Center in New Orleans, and she completed a surgical critical care fellowship at the University of Texas Health Sciences Center in San Antonio in 2020. We were fortunate to recruit her to our surgical trauma critical care faculty at LSU in New Orleans, and she was boarded in general surgery and critical care medicine. And so we have an esteemed group of panelists here today who will impart a lot of knowledge on wellness and ergonomics. So first, I'd like to invite Dr. Amy Hildreth to speak about organizational approaches to wellness.
Thank you very much, Dr. Stewart, for the kind introduction. I'm very excited to be here today talking to you about some organizational approaches to wellness. And I will focus my talk today on psychological wellness in contrast to some of the following talks. So I have no disclosures. I was fortunate in 2017 to be asked to be part of the Action Collaborative on Clinician Wellbeing, sponsored by the National Academy of Medicine, where they convened a number of participants to discuss clinician wellbeing and the recent crisis of wellbeing among clinicians. And in that group was featured clinicians such as myself, as well as other stakeholders, including insurance payers and EHR participants, CMS, a variety of other stakeholders in the wellness space, as well as content experts to really dive into this issue. So to back up just for a moment, the impetus of the development of this Action Collaborative was really this epidemic of burnout in the United States. And as you've heard in previous talks, even at this meeting, burnout is characterized by high emotional exhaustion, depersonalization, and a low sense of personal accomplishment, specifically from work. And really over half of physicians and nurses have been documented to have burnout even before the pandemic, and over 60% of medical students and residents. And burnout has been shown to have adverse outcomes, both personally for these physicians, as well as in terms of patient outcomes and medical errors. We know, however, that at baseline, U.S. medical students before they enter medical school have the same levels of burnout as their age-matched peers. But compared with these samples, as they progress through medical school and their residency and fellowship training, they are more likely to develop burnout over time compared to their age-matched peers. And they are also more likely to develop symptoms of depression. And so one of the biggest things that I learned from the Action Collaborative and the content experts there is that the burnout epidemic is not a sign that we are broken. We are not broken, and our generation is not broken. The system is in fact broken. And the reasons behind that are too complex to discuss here in 7 minutes. But certainly COVID-19 pandemic did not improve any of the circumstances in which we practice. One of the first things the Action Collaborative put together was this conceptual model, which really reflects all of the factors that play into physician well-being. And you can see at the center, there's the patient and the physician relationship extending in those green circles out from the patient. And the factors on the outside are what affects our well-being and our relationship with the patient. And featured in yellow are the external factors, and featured in blue are the internal factors. And you can really see that factors outside of us really have a disproportionate impact on our well-being. And are there interventions that are helpful in improving well-being? It's been shown that in a meta-analysis in Lancet in 2016, that there are various individual and organizational strategies in a number of randomized controlled trials and cohort studies that have been found to decrease burnout. Each of these is effective in a different population and really has to be customized to who it's targeted toward. In a subsequent study in surgery in 2022, they found that junior faculty specifically have well-being that's influenced even at the department level, and so influenced by the very local environment. And for surgery residents, in a recent study in the Journal of Surgical Education, increased work engagement and job resources correlated with decreased burnout rates. And so you can see in our populations that really burnout can be prevented by very local factors, and that external factors may be more important than changing internal factors. At the conclusion of the National Academy of Medicine Action Collaborative in 2022, the plan was put forth for health workforce well-being for the entire nation. And really the vision is that patients are cared for by a health workforce that's thriving in an environment that fosters their well-being as they improve population health, enhance the care experience, reduce costs, and advance health equity. And you can see the whole plan, which is extensive and available at the National Academy of Medicine website. But they really wanted to focus going forward on a number of key priorities. There are 7, including creating and sustaining positive work and learning environments and culture, investing in measurement, assessment, strategies, and research, because as we've seen, there is little data about what's effective in what population. And so more work needs to be done to determine how we can best combat burnout and promote well-being. To support mental health and reduce stigma, to address compliance and regulatory and policy barriers for daily work. I know if your workflow is anything like mine, that there are a number of factors that really do not promote wellness that you and I encounter on a daily basis as we go through our day that certainly could be improved. Engaging effective technology tools. So how can we make the medical record be a tool to help us instead of an obstacle? How can we use technology to improve our lives rather than to create barriers? Institutionalizing well-being as a long-term value, and then recruiting and retaining a diverse and inclusive health workforce, recognizing that that's a key element of wellness that we can't overlook. And so from my work with the National Academy of Medicine and through my individual thoughts, as I've tried to incorporate some of these strategies into both organizations that I've been a part of and my work as a program director, I have some opinions about effective interventions at the organization level. The first is that effective leadership is really a wellness intervention, that there are studies that show that wellness correlates with effective leadership strategies. And I've found that to be true in my personal experience as well. That major decisions in a department and organization should really be evaluated through a wellness lens. Anytime you create a new program or a new requirement, that the follow-up question should be, how does this affect the physicians, the surgeons, the trainees that it's intended for? That intervention should have buy-in from those that they affect. Not that your residents are going to be able to suggest all of the interventions that you might implement in your program, and not that your faculty or the members of your organization will generate all of the ideas, but that they should have buy-in for something that you're going to implement. That it doesn't have to be expensive to be effective, although sometimes it might be. That your interventions should be based on available data, in the case where data is available, and targeted to key populations. And so you have to recognize which of the populations that you're serving, either in your organization, your department, are at greatest risk for burnout and altered well-being, and target those specifically with your interventions. So in conclusion, burnout is prevalent and the consequences are significant. And the interventions at the individual and the systems level can be effective, but physicians at baseline are already very resilient, as documented in the literature. And so systems levels interventions may have a bigger bang for your buck. There's really no magic bullet, and interventions will have to be multifaceted, and that we all can in our individual leadership roles and have a responsibility to influence surgeon wellness. Thank you very much.
Next, we'll have Dr. Shanita Johnson, Ergonomics and Robotic Surgery.
I'd like to thank the Congress for the privilege of the podium and to talk about surgical technology and how it's impacting our ergonomics. Let's set the stage for this. When we talk about ergonomics, Merriam-Webster says that this is an applied science concerned with designing and arranging things people use so that the people and things interact most efficiently and safely. And I want to really focus on that last word, which is safety, which is why we're here. We're here for patient safety, but also our own safety as surgeons. And so that is the framework that we're going to discuss the impact of robotics and ergonomics. There's certainly a challenge when we think about ergonomics in surgery because there's multiple variables. Our patient body habitus varies from patient to patient, and that impacts the way we stand, the way we look, the way we twist our body in order to complete the procedure. There's constraints of the sterile surgical field and what that means for how we must approach the procedure. There's a wide variety of operative techniques, endoscopic, laparoscopic, open, and robotic. The patient positioning itself also plays a role in how we must stand and position ourselves and the team to complete the procedure safely. And then our own stance and posture plays a role. How are we standing? Are we aware of our posture as we're moving through the procedure? Unfortunately, there are sequelae of poor ergonomics, and some of these include musculoskeletal damage. There may be damage to the cervical spine, to our shoulders, rotator cuff injuries, and injury to tendons and ligaments. And this damage may cause nerve compression and ischemia. We may feel neuropraxia. There may be spinal cord compression from the way that we stand and prolonged standing over time. And that can over time cause a decrease in our truncal height. Certainly laparoscopy has some benefits, shorter hospital stay, decreased postoperative pain, but it does also have significant physical demand, standing for long periods of time, looking at a screen. Park et al. Looked at laparoscopic surgeons, and 87% of them that were surveyed reported work-related symptoms and injuries. And the most frequent were cervical and lumbar spine strain, shoulders, wrists, and hands. So in came robotic surgery. And is this going to help us? Certainly, it's been around for a long time. We're now 23 years into the FDA approval. Most hospital systems have access to it. It has certain benefits that we like, the 3D vision. We like having wristed instrumentation similar to our own wrists when we were doing open procedures, improved dexterity and accuracy, ease of suturing. We remove the fulcrum effect at the level of the trocar. And so we have increased ease of doing procedures and adhesiolysis, et cetera. And it overcomes some of those laparoscopic limitations, like the fulcrum effect of the trocar is no longer there since we have an end effector that's intracorporeal. We certainly have depth perception back, going from a 2D to a 3D system. We've removed instrument tremor. We have improved intracorporeal suturing and improved safety and a decreased operator workload. This system is being rapidly adopted throughout the United States. We see significant growth year over year in the United States. And that is in all areas, general surgery, thoracic, colorectal, to name a few. And then we look in academic societies and you can see that tremendous growth that we see with robotics over the past few years. So certainly when we look ergonomically, we can see some obvious benefits. We're in a seated position to do the procedure, so we are not standing, so we should decrease that spinal compression that I talked about earlier. The robotic arms are very easy to move. We don't have to use a lot of effort to move those arms. The camera is set with a downward gaze that should minimize eye strain and fatigue, and you can adjust your ergonomics to suit you personally as what would be optimal for your ergonomic position. And you can use a supportive chair to help. There have been surveys that looked at robotic surgery and it's associated with a lower self-reported physical discomfort compared to the open and laparoscopic procedures. Zinni et al. Took a look at laparoscopic surgery versus robotic surgery, and they found that laparoscopic surgery was associated with elevated muscle activation in all of the muscle groups compared to robotic surgery, except the trapezius. And then Lawson showed that robotics was associated with decreased arm, forearm, and wrist discomfort. However, they also found a greater rate of neck strain due to the position of the upper torso. Fanasiak took a look at this, took a look at robotic surgery ergonomics, and also an ergonomic training program. Of the surgeons that he studied, 45% reported experiencing some strain. 70% of them reported that it was neck discomfort. But when we look at a formal training program, only 16% had undergone any sort of formal ergonomic training, whether that's from industry, or from the hospital system itself. He then asked if they would like to undergo a formal training system, and 88% said yes. Of that 88% that said yes, 74% of them had a decrease in strain when they implemented the recommended positions. So how do we improve ergonomics with robotic surgery? Certainly, console familiarization, being aware of your body as you're sitting at the console, frequent clutching to readjust your position. Physical activity and training. We are like athletes. We spend a lot of time doing a very physical job. So making sure that we are physically active is important. And then formal training, as in the study that I just mentioned, so that we're aware of the optimal ergonomic positions. So I won't go through all of these, but this is some of the optimal positioning with robotics, making sure you're at a neutral position, making sure you're reevaluating yourselves, that your knees, elbows, arms are all positioned appropriately, that your head and neck is not more than 20 degrees leaning forward. So the college actually has a surgical ergonomics clinic that they began. And they found that there is some value in an individualized ergonomic assessment for every practicing surgeon. And they implemented their first hands-on clinic at the Congress last year in October. They had 3 stations for open, laparoscopic, and robotic surgery equipment with a hands-on learning experience. And they had coaches and physical therapists available to assist with this ergonomic coaching. So to end here, the robotic surgical platform addresses and alleviates some of the ergonomic deficiencies we see with laparoscopy, but it doesn't alleviate all. And so certainly we have interventions and formal training that should be employed in our systems to improve surgeon ergonomics.
Next, we'll have Dr. Valentine Nafonsa, recognizing and mitigating the second victim syndrome in surgery.
So I want to thank the organization for giving me this opportunity to talk about something that we rarely talk about in surgery, but impacts all of us. I have no disclosures. So I'm going to start with a case study, which I can't really read from far away. It's so small. So you have an experienced surgeon who performs an elective laparoscopic cholecystectomy on a young woman who happened to have to be a single mother and has 3 kids. So during that operation, dissection was difficult, but the surgeon was able to actually complete that operation. And 5 days later, that patient actually shows up in the emergency department with some abdominal pain, nausea, jaundice, with a bilirubin of 12. Imaging studies were actually done that showed a transected common bile duct. This was actually near the junction of the right and left hepatic ducts. So an HPV surgeon was, of course, called to see this patient and consulted with the patient and advised this patient that she would need to wait for about 8 weeks before any surgical intervention. So the initial original surgeon goes and sees this patient, and she begins to cry and complaining about not being able to get out of work for 8 weeks and how that is going to impact her significantly. Of course, the surgeon was very distraught and very sympathetic to this patient. So how many times do we, some of us have been in that situation? So of course, this was discussed in the M&M and the conversation was more centered around the surgeon's technical skills and also the surgeon's decision-making. So we all know that if you're a surgeon and you don't have complications, then you're definitely not operating. So most surgeons would have complications. How we manage this complication is important. And So the system actually recognized the fact that this happens, but most of the times the surgeon is chastised. Again, the clinical judgment and technical skills questioned. There's rarely a time that we sit and think that this surgeon might have some emotional problems dealing with that complication. So, and this, we see that on Monday morning quarterbacking, talking about complications in M&M, and rarely does that surgeon ever been considered as a victim, which is the second victim. And so that term second victim was actually described by Wu in 2000, and it pretty much refers to any healthcare provider who suffers emotional distress following an adverse event or medical error. And this is something that we face every day in surgery because there's a lot of complications happening now when we are operating. So over the last several years, there have been a lot of talk about how we can mitigate complications, but there's not been a whole lot of conversation about dealing with the second victim syndrome. And that information has been very limited. So, so the second victim is actually, you do your operation, probably the only one who had seen that patient prior to surgery. You've invested time in clinic dealing with that patient. You've talked to the patient's family, and we're all, most of us, emotionally attached to our patients as we bring them to the operating room. Surgeons, not so great behavior in the operating room has been actually channeled or been indicated that this is just due to the fact that they know their patients a lot and they care about their patients, and most of the times they feel like nobody else in that operating room care about their patients. But bad things can happen. So if you're a second victim, most second victims will have two things: a deep personal commitment to the safety and welfare of others, which they do, and also they work in an environment where safety is generally critical, and it's also characterized by a high level of complexity, frequently involving rapid decision-making, which is something that we do as surgeons. So there is an intersection between those two, and most second victims would have this. And so surgeons are a classic example of facing the second victim syndrome. So in this study, the authors actually ask a lot of second victim people what they feel. And you see, there were a lot of emotions involved here. Some felt grief, some felt confusion, exhaustion. But one of the things that really stand out there for me is self-doubt. How many times have we seen our colleagues that get into a major complication and they doubt themselves about even doing that operation again? And so there's a whole lot of emotions that are involved here. So there's several actually stages of second victim syndrome. So initially when this happens, there's a whole lot of chaos and accident response, and they spend a whole lot of time doing some kind of major and deep reflection. And you go through restoring your personal integrity, and then the inquisition starts, where you're sitting in M&M, and that might include a peer review in your institution. And in most of the times, rarely do people actually care about the emotional turmoil you go through when you're dealing with that complication, especially if these are patients that you actually knew pre-op and you, of course, care about them so much. So that actually affects you. In the end, you're going to move on after you survive that inquisition. But so what do second victims really need? I would say they need support and from peers that are trained in this support system. They also need just general support from their peers, and they also need professional help. And they might just need somebody to just talk to, somebody they can confide in, somebody who can actually help them recover, somebody who had complication, but more importantly, the struggle. A lot of people struggled because there was absolutely no support. And, especially going through the inquisition of M&Ms and also your peer review system. So these are some of actually the way these surgeons actually felt. They felt some of them were ashamed, some of them felt anger, guilt, and again, so many different emotions. But more importantly, there was no emotional support provided. And so Dr. Kafrani has actually done a lot of work in this, and at Mass General actually developed what we call a peer review, or a second victim program. And this second victim program, where they actually nominate members of the faculty at different levels, all the way from residents to faculty. And then they form a peer reviews support group, which is selected from this nomination. And then there's actually actual training of the peer review group. And these are people who can actually intervene and actually deal with the patients or the candidates with second victim problems. So what does the peer support group do? It actually matched the surgeon's experience with a peer supporter. And then it just takes time to either listen to the surgeon victim. In addition, the whole point is not just listening or providing emotional support. It's also ways, you also look for ways to actually improve technique and also improve decision making. And so the patient is still the center of this intervention. But in addition, the second victim is also considered. And so the three different phases in management of second victim syndrome, that includes prevention, mitigation, and support. And this actually reduces the incidence of medical errors by promoting physician and emotional health before it happens. So that's the prevention stage, and mitigation is at the level of immediately after there's an adverse event. And then support is just really not providing blame, but more looking for ways to actually help the second victim, but more importantly, trying to prevent complications from happening. The AHRQ, care for the caregiver, actually came up with this algorithm that puts it into 3 different tiers. And the tier 1 is just pretty much at the level of the department providing support. And tier 2 is where you have trained peer supporters. These are your colleagues and also maybe residents. And tier 3 will be a referral to an external network. So just in conclusion here, the second victim syndrome is actually real, especially in surgery. And in surgeons who have an adverse event happen should actually be looked at as second victim, and interventions should be is warranted. So when you sit in your next M&M and chastising somebody, think about what emotions that person has facing those complications. Thank you.
Next, we have President Dr. Brian Richmond. He will give ergonomics and surgery a personal perspective.
So first of all, I'd like to thank Dr. John Stewart and the program committee for inviting me to share my personal experience with surgical ergonomics. As you know, ergonomics in surgery has gotten a lot of attention over the past few years, and almost every major surgical meeting that I've attended has had a session on ergonomics and its relevance to a surgical career. Now, I don't hold myself out to be an expert in the subject matter, but as some of you know, I have had a very personal experience dealing with the consequences of the ergonomic challenges of surgery and their consequences on the human body. I have no disclosures other than I'm currently wearing about $15,000 of Medtronic titanium in my neck. So work-related injury among surgeons is common and affects anywhere from 47 to 87% of surgeons in practice. The development of musculoskeletal pain and other symptoms while operating is attributed to long periods of standing, sustained adverse postures like sustained neck flexion, non-neutral positions, repetitive movements, limited recovery time, and the use of non-ergonomic equipment, including laparoscopes, instruments, loops, headlights, and lead aprons. In addition, the strain brought about by poor workplace ergonomics is likely exacerbated by altruistic attitudes among surgeons, with many surgeons prioritizing the health and safety of their patients while neglecting their own comfort and well-being. As a consequence, work-related strain can certainly impact the surgeon's physical and mental health, as well as the quality of life and ultimately even career longevity. So I think one of the most interesting aspects of surgical ergonomics is the fundamental question as to who is most likely to be affected. In addition to the circumstances mentioned above, there are genetic predispositions to spine-related problems, and people may engage in other activities that may threaten the health of their spine. And in my youth, I was one such person. So when I was young, I was a wrestler, and I took it very seriously. I was not blessed with a tremendous amount of athletic ability, so I trained very hard to be the best that I could be at the sport that I loved. Now, this slide depicts a wrestling maneuver called bridging, and if you show this to a spine surgeon, you'll probably get one of three reactions. They'll either faint, throw up, or have a panic attack. But the move involves the wrestler arching his back to elevate his shoulders off the floor, and in do so, avoid being pinned. This move is commonly trained among wrestlers of all ages, even in elementary school programs. And frequently, the coaches will have the wrestlers train this maneuver with the weight of an opponent on their chest. And the goal is to build a strong neck. And what it in fact does is destroys your neck. Exercises like these, as well as being forced to perform this maneuver in a match, was a fixture in my life for probably 15 years. So not surprisingly, while wrestling in a tournament in college, I suffered my first major disc herniation. I had paralysis of my left bicep, frequent fasciculations. I lost 60% of the grip strength in my left hand, and I was completely disabled with neck and shoulder pain. I was seen by a neurosurgeon, was offered cervical fusion at C5-6, which I declined at that time because I was starting medical school 4 months later, and I was afraid that I wouldn't be fully recovered and wouldn't be able to start. So things gradually got better with time. My strength returned and the problem went away, but would resurface every few months. Surgery residency and its hours added more wear and tear, and this was compounded by a surgery career and a surgical culture, which involved the regular performance of laparoscopy, the wearing of loops, and just dealing with all the other challenges that the OR environment provides. So things came to a head in 2016 when I started to have such severe neck, arm, and shoulder pain that I could hardly get through the day. Some of you may remember that time. I was in really bad shape at the 2016 Southeastern meeting in Atlanta, and I was completely miserable. Then after that, even worse, I developed such extreme sensitivity of my left fingertips so much that I had to wear a glove to be able to stand it. I had bilateral hand weakness, a winged scapula on the left, and a paralyzed tricep on the right. So this was my before picture. You don't have to be a neuroradiologist to tell that is not a normal x-ray. And on March 16th, 2016, I went into surgery and I had 4 cervical vertebrae fused using a titanium plate, screws, and 3 bone grafts. So this is my after picture. And interestingly enough, this was done by one of my former medical students who trained in spine surgery at Mayo and then came back to join us. So this is my after picture. And since that time, I've become free of all neck, arm, and shoulder pain. And I've recovered about 80% of my upper extremity strength. I'm grateful that I didn't have to interrupt my surgical career for more than 6 weeks, but injuries like these have certainly been those that have shortened promising surgical careers. And although I may have been predisposed to this because of the activities of my youth, there's no question that the wear and tear of both the surgical lifestyle and a surgical attitude added to my problem. So this is not a new issue. This article, published in the archives in '99, provided an overview of many of the ergonomic issues facing surgeons at that time. And as recently as June of this past year, JAMA Surgery published an article on ergonomics as well. Articles have also started to appear suggesting that surgical ergonomics should be integrated into the surgical residency curriculum in an effort to prevent injuries and to prolong the careers of promising young surgeons. In these papers, a number of strategies have been suggested for improvement, and I'm sure the panel will discuss these in more detail as we move on, but these are a few. I think the first centers around awareness. We all need to be aware that surgical ergonomics is an important issue, and we need to make this part of the conversation in the operating room. We need to correct bad behavior when we see it, and we need to maintain a healthy operating room culture that takes care of its employees and takes care of its surgeons. It's important to maintain a strategy of general wellness. Maintenance of a basic fitness level, which includes core strengthening and stretching, is important, not only for overall health, but for career longevity. Special technologies are emerging, some of which have ergonomic implications. Ergonomic loops that allow the neck to be maintained in a more neutral position are now available. Instruments are being designed with ergonomics in mind. And as Dr. Johnson mentioned, it's possible that increasing use of robotics may, if properly done, provide a more ergonomic alternative to traditional laparoscopy. And finally, the adoption of micropauses, where scheduled 20-second rest breaks are regularly taken during surgery, may diminish the ergonomic impact of long and tedious operations. So in conclusion, we need to be aware of the effect of poor ergonomics on the health, wellness, and even the career longevity of surgeons. And for this reason, I believe that awareness of ergonomics should become a necessary competency in surgical training. So once again, I'd like to thank the program committee for the opportunity to participate in this panel, and I welcome questions and comments at the conclusion of the presentations. Thank you.
Next, I'd like to invite Dr. Allison Smith to the podium. Provider Wellness in the Face of Escalating Violence, a Trauma Surgeon's Perspective.
Thank you, everyone. I'd like to thank Dr. Stewart and SCSC for this opportunity to be part of this esteemed group of panelists. I have no relevant financial disclosures. So really the crux of this talk is going to be about really how as providers we deal with some of the violence that we see, especially as trauma surgeons, which is what I do, and touch a little bit on what Dr. Fonson mentioned in his talk about the secondary victim syndrome. So as we all know, it's been mentioned multiple times that the United States has had this escalating violence pattern, really, has taken off after the COVID-19 pandemic in the form of job insecurity, financial difficulties, unstable housing, inflation, lack of resources and access to mental health. We've also seen changing patterns of violence. There in particular has been an increase in violent crimes, which are defined as robbery, rape, aggravated assault, and homicide. I'd like to turn your attention to the table at the bottom of my slide. Being someone who's lived in Louisiana for over 16 years, we're usually at the bottom of every list. Unfortunately, we've made the top of this list. This comes from the FBI Unified Crime Report in 2021, and Louisiana is the highest in terms of violent crimes per 100,000 people. And also we have a very high poverty rate as well, which can escalate some of these issues. So in particular, in New Orleans, where I practice with several of my partners who are here in the audience as well, we had 280 homicides in 2022, which is the highest number since the mid-90s. We've been dubbed the murder capital of the United States. We've also had an increase in carjackings, burglaries, theft. We've also had this trend in terms of highway shootings, where we found that patients have been driving in the highway and they have been involved in gun violence, and it's kind of unclear as to whether this is something that is a known shooter or not. As a result, New Orleans has been ranked among one of the most violent cities in the world. So where I practice, we are a level 1 trauma center that serves the New Orleans area and the surrounding state of Mississippi. And we've seen kind of a steady increase in yearly trauma admissions since the COVID-19 pandemic in 2019. We have about over 5,000 trauma patients per year. In particular, we are about a 30% penetrating trauma rate at our trauma center. And the area around us, which is Orleans Parish, we have about a 60% penetrating trauma rate. And if you've never been to Louisiana, we don't use the term county, we use the term parish. So it's kind of, really staggering when you think about those numbers. And for me, as somebody who trained in New Orleans, I'm not from New Orleans, and it can be exciting to have a lot of penetrating trauma during a trauma call shift, in particular as a junior faculty member. But as somebody who is a proud member of the New Orleans community, it can also be frustrating and make me concerned about my family's safety as well. And as has been mentioned before, and I know you all are dealing with the same issues, there's been a lot of staffing shortages and also provider burnout, which have really exacerbated a lot of the issues that we're facing on a daily basis. So when I was asked to prepare this talk, it really made me think of 2 personal experiences that I've had and really how that's kind of shaped how I approach some of these issues as a trauma surgeon and healthcare provider. When I was a college senior, I was at Virginia Tech during the mass shooting that occurred. I actually was walking to campus when the shooting was happening in Norris Hall, which ultimately claimed the lives of 32 students and professors, and the shooter was the 33rd person who died. That experience to me was very traumatic in terms of just seeing how it impacted friends that I had, professors, and also just Virginia Tech being a very close, tight-knit community, just going through all of that trauma and the invasiveness of the media and the world just wanting to be there and to know what we were experiencing. And then after I moved to New Orleans, started medical school, during my 3rd year, I had the opportunity to travel to Haiti, where I landed about 96 hours after the major earthquake there in January of 2010. I spent about 2 weeks in the university hospital there, which cared for a lot of the earthquake victims. And really that experience, though it wasn't my own community, I felt very invested in what happened to those patients and really just seeing the amount of trauma and hardship that were plaguing the patients there. When I came back from that experience, it was kind of very early on in my medical career, and I was able to channel a lot of that into an organization that I started called Santé Totale that still operates in Haiti today. But even still, especially now with the news coming out of Syria and Turkey, it definitely brings back a lot of flashbacks to just really all the trauma that patients experienced during that time period. So really, as a result of that, what I think the takeaway and really what we deal with on a daily basis is just thinking about kind of the secondary traumatic stress that, as healthcare providers, that you yourself might not be that person experiencing that trauma, but that's something that you take on as you care for that patient. That's really a difference from PTSD, which is caused by a primary exposure to the traumatic event. And that's something that I, as a college student, has experienced being within that community and being primarily exposed to that event. And these 2 terms should be differentiated from burnout, which is long-term non-supportive work environment. In terms of secondary traumatic stress, I listed the symptoms there. They're very difficult to differentiate in terms of PTSD, depression, other physical ills that you might be experiencing. It really can be hard to diagnose and pinpoint it. Prevention is best, but it's obviously very difficult given all the stressors that we have and all the constraints that we face as healthcare providers, how to prevent this. But if you have investment of the leadership, trainings and support groups, you really can hopefully help to improve the ability of healthcare providers to deal with these traumatic stress events. In particular, trauma surgeons, we're at an increased risk of experiencing these secondary traumatic stressors, just given the nature of our job and the patients that we're taking care of. There was a study that was done in 2014, which surveyed trauma surgeons who were experiencing what they term PTSD. The really secondary traumatic stress is the more appropriate term. And they found that risk factors included male trauma surgeons having greater than 15 cases per month, greater than 7 call shifts per month, less than 4 hours of relaxation per day, and greater than 5 critical cases per shift. And I'm sure for those of y'all who practice in trauma or even just other surgical specialties, there's definitely some of those risk factors that might apply to you. They didn't find any difference in terms of salary, prior military experience, or years of experience as a surgeon. And then there's been a lot of literature coming out with how the COVID-19 pandemic has impacted trauma surgeons, critical care surgeons, and even extending that to emergency medicine physicians who are really on the front line in dealing with all of this. There wasn't an increased self-reported PTSD, but there definitely has been a lot of changes in terms of how providers are responding to that and how the workplace should really be sensitive to those experiences that you might be having. In particular, in the trauma world, there's something called trauma-informed care principles, and that not only takes into account the patient and making sure that we as healthcare providers don't re-traumatize them, but it also takes into account how you as the healthcare provider might be experiencing some of that secondary trauma from taking care of the patient. So in conclusion, we've talked about here some of the potential solutions that could have. Obviously, we're having this discussion at a major conference, and I've attended several other major conferences where really there's been this push for wellness. So we might not have all the answers, but I do think it's good that we're engaging in the conversation. What we have at our trauma center is something called psychological first aid for healthcare providers, which really focuses on structured debriefings, having frequent check-ins, support groups. And then we're also in the process of developing a trauma recovery center initiative. And Dr. Erica Rajo, who's our trauma psychologist, wanted to make sure that I mentioned to y'all that it's important to think about you as an individual and making sure that you're looking into self-care and also considering therapy if it's something that could potentially help you. So I'm looking forward in our discussion to talking about what ideas you all also have as well to how to improve this solution. So thank you all so much for this opportunity.
So as the moderator, I'd like to thank our panel participants for an outstanding panel. I think each of you brought your own experience to our panel that can help us further our conversations around ergonomics and wellness. Do we have any questions from the floor? Dr. Green.
Wendy Green, Emory University, Atlanta, Georgia. There have been a rash of suicides, and the impact that it has that has happened on the community in which they've been involved, like some of the pediatric surgeons. And in some of our wellness groups, we've been talking about, how we can, from the American College of Surgeons side, be able to put more programs in place so before people get to that point, they have some means of having an outlet. And one of the concerns was also getting people back into the work environment after they've had a struggle with either substance abuse, their license has been put at risk, and how we can help mitigate some of those extra stressors by, as an organization, being able to intervene with some of those difficult situations that people may face. So do you have any ideas when you are looking for how to help your colleagues who may be on the edge and you're seeing them and they're not quite looking right, and you're like, are they going to be at risk? What would you suggest be some of the first steps? And then if they have had problems either with substance abuse, what steps we might be able to do from an advocacy standpoint to be able to safely be able to reintroduce them back into their careers? Thank you.
Yeah, I can try to tackle those. Yeah, certainly it's identifying colleagues at risk for mental health concerns, and in particular risk of suicide is a difficult place to be in as a colleague, because you are in this position where you are concerned about your colleague, but you don't want to pry or don't want to intervene in any obstructive way, but at the same time want to make sure that your colleague has the appropriate care. I think one of the things that's would be important to put in place to try to prevent suicide would be to do some sort of routine screening. I know there are residency programs that have implemented, at least a scoring system that involves texting. Certainly there's screening as a program director that I do in my program when I meet with residents twice a year. But you're right that that's not always going to identify someone in a time of crisis. One of the things we've implemented in my department is an ombudsperson program, which can address a number of issues within the program. But one of the things that has come up several times is a resident speaking about another resident who has a mental health concern, and you telling the ombudsperson in an anonymous way so that we can sort of reach out and get them the help that they need. And so I imagine for faculty, a similar program might be helpful as well. Regarding substance use and returning to practice, certainly I think states in general have very supportive programs to help that happen in a productive way. One of the things that I think has happened recently is in terms of reporting for substance use on applications like licensing applications and that sort of thing. A lot of them now say if you are in your state sponsored program for impaired physicians, you do not have to report this in your licensing application, which I think helps in decreasing the stigma. And one of the things that we've actually talked about at the American Board of Surgery and the Diplomats Committee, I don't know if it'll come to fruition or not, but one of the things that's been suggested is that if someone has an action against their certificate and is then returning to full practice, that we have discussed the potential to develop a mentoring program for folks to return back to full practice, maybe with people who have been in a similar situation before. So that's an idea that's in its infancy, but certainly something we can do as an organization to support.
And I would just add to that too, that it's something that Amy brought up that's important. I mean, obviously you want to protect the public and protect patients. So the worst thing you could do is not say anything in that circumstance. But I think that there's a huge difference in the course of action that's taken when a person submits voluntarily to a physician's help program versus a mandated treatment program. So I think being proactive and encouraging people who you think are potentially impaired or in some way distressed to seek voluntary help, urge that as a colleague, because as Amy said, and many times that can allow them to seek treatment anonymously. They won't have to report it. There won't be actions on their license. There won't be actions that go to the data bank, and the patient is ultimately protected and the physician is more likely to return to a productive practice. So I think the intervention at the, at the chair level, at the program director level, at the division chief level to say, listen, we think we might have a problem here. We notice that we want you to be well. You're going to do a lot better if you seek this help voluntarily, which is sort of semi-anonymously. And we've seen those programs be greatly successful in West Virginia. And once again, on the credentialing application in West Virginia, it says, if you are currently enrolled in the Physician's Help Program, you can answer no to this question. If it asks you, have you ever had an issue with substance abuse? But that's if it's voluntary.
I want to just add to that, having dealt with situations like this a few times as residency program director and as division chief of surgical oncology, it's very difficult to anticipate or prevent this. I think that you have to create an environment where people trust you to be able to come up to you to talk about this. I've had a situation where a resident came up to me and told me that they have major drug issues and the relapsing and stuff like that. And so I think for me, it was a great step for that resident to step one, because there was a whole lot of trust between myself and the people around for that person to open up. And he sought treatment and he was reintegrated back into the residency program 6 months later, and he's an attending now and doing well. I've had a resident who was, I noticed that his evaluations just plummeted and, getting not so great evaluation, and brought him to the office and we just talk about it and what's going on. And he was on the verge of suicide because he was so deeply depressed and on multiple medications and still not working. And so I think you have to you can have all the tools around, you can give them all the numbers to call. You have to create an environment of trust where people can come up and actually lay out their problems. If you look around and look at all the suicide prevention studies, will tell you people look perfect, normal, and then they kill themselves the next day. So there should be an environment. If you can create that environment where people can step up, we're going to do a whole lot more in addition to all the adjunct stuff of like all the resources that are out there. And people know these resources. They just don't trust going to those places. And so, and it's just not an easy thing to tackle.
To build on something that Dr. Fonson just said, is that one thing that I've learned as a residency program director that I think I'll take with me throughout my career is that a performance problem is always a physical or mental health problem until proven otherwise. That if you have an underperforming resident or faculty member or colleague, that you always have to rule out some sort of mental or physical health concern first, because I've had experiences with residents where it looked like a performance with doing progress notes or declining operative skill, and turned out to be a severe depression instead. And so just an important thing to remember.
Okay, this has been a very stimulating panel. We're up against the clock, so we'll take one more question.
Good evening, everybody. Thank you very much for the amazing, stimulating discussions today. My name is Dider Abdullahi. I'm a Morehouse General Surgery resident. I just have two questions, and it's specific for the ergonomic and it's very important to have some sort of support system, and it doesn't exist. The recovery center that you mentioned, we have it for patients as well, but none of it exists for, trainees and attendings. So I'm just curious if you can discuss what you see as an ideal training situation for trainees and attendings and medical students who are in those environments, so we can thrive and do the best that we can. Thank you.
So I'll address the first part of your question. I certainly don't think that what I'm suggesting is that the knowledge of ergonomics be integrated into the curriculum formally, like in the context of an EPA. But I think that it's more of a cultural competency that we need to create, where, you get in the habit of saying, stand up straight, hold your head in a neutral position. Let's take a minute, do a micro pause. Your ergonomics are terrible, just kind of, and focus on opening that conversation, because bad habits start early and they're hard to break. So I think if we start, training, just like you train proper technique in the handling of tissue, the way you pass the suture, the way you tie knots, I think the same could be said for body position and how you approach certain procedures. And then, as it was mentioned, robotics, they can be helpful, they can be harmful. So learning how to position the console so your head's in a neutral position, the instruments at the correct height, all these are things that I think sometimes get neglected in the education of the procedural aspect of surgery, but it needs to be part of the conversation.
From the presentation and the research for the presentation, I think formal training needs to be a part of this. And Dr. Abdullahi is one of my residents, so it is to come. That we will incorporate formal training of ergonomics, because we have seen the literature that supports it, that makes a difference. And we want certainly to see a longevity of your career. So we need to start that very early. As Dr. Richmond mentioned, we are behind. It should probably be in medical school training. And then as you start your surgical training, we certainly should back that up with training.
Great. Again, thank you so much, panel, for a great discussion. We have Dr. Smith, one
Yeah,
last comment.
just real briefly, in terms of your question, I applaud you for asking that question because I do think sometimes we forget as attendings and residents, really the impact that some of these really traumatic events as healthcare providers have on trainees, not only on ourselves. So in terms of the resources we have available, I think it's really also a cultural change. The trauma-informed care, we're lucky in that we have a great team that even though it is focused mostly on patients and screening patients and getting them trying to plug them into the PTSD clinic. Now the effort is expanding more so to how it's impacting healthcare providers as well. So we have several quality improvement studies looking at how we can improve that for our healthcare providers, our trainees, but also making sure that what we're doing is going beyond just having structured debriefings. That's kind of what a lot of people go to when you have a particularly traumatic event, everybody debriefs. But what I'm told by our trauma psychologists that that's really not as effective. So we're really trying to develop more of these initiatives, and I'm happy to share them with you afterwards and kind of give you some of the resources that we are trying to put in place. And I do think one of the big important things too is we're looking at prevention. And I think that that's also a good way to help channel your efforts, particularly for us seeing so much gun violence, that instead of just tolerating it and accepting that we're going to have that 30% penetrating volume, we're also trying to outreach in the community and make sure that we're trying to make a difference in terms of what we're seeing with our patients, but also where we live and practice as well.
Great. Thank you so much, panel. Thank you for your comments, and thank you, audience, for your attention and participation. I think we're moving next to the business meeting.
Yes, so if you'll please remain in the room, we'll go ahead and move directly to our business meeting, and that will conclude today's activities.